In this lecture, I'll be covering COPD exacerbation, which is one of those bread and butter diagnoses that you should be familiar with. Here are the learning objectives and the recommended reading. As you should probably already know, COPD is chronic, it's obstructive, and it's irreversible. The diagnosis of COPD is first based off of symptoms, including shortness of breath, cough, and sputum production. Once these symptoms are present, you should get spirometry to confirm the diagnosis and determine the gold stage the patient is at. The two key features to diagnose COPD are an FEV1/FVC less than 70%, followed by an irreversible FEV1 with bronchodilators. This second spirometry finding is what determines their actual gold stage. Now, this is great in the outpatient world. However, inpatient, you may not have these available. Therefore, you may have to diagnose it clinically, taking into account a patient's symptoms and risk factors, including the number of PAC years the patient has. Obviously, the FEV1 is going to decrease with the number of PAC years the patient has. Also consider alpha-1 antitrypsin testing in young patients, and typically in those that don't smoke but have signs and symptoms of COPD. This slide will review the basics of spirometry. So normal breathing in and out is your tidal volume, and that equals around half of a liter. When you take a deep breath, then exhale as much as possible, this is your vital capacity, and that's around 5 liters. Even though you've exhaled all of the air possible, you haven't. This leftover air is called the residual capacity and is around 1.5 liters. So total lung capacity, or the total of all of these volumes, is around 6.5 liters. The FEV1 is the volume forced out of the lungs in 1 second. When this percentage is improved with giving albuterol, the patient has asthma. When this does not change with bronchodilators, they have irreversible obstruction and thus have COPD. Once spirometry has confirmed the diagnosis, next you need to assess the degree of airflow limitation. This is when you determine the gold stage the patient is in. Based on the FEV1, not the FEV1 to FVC, which is used to make the diagnosis, but based off the FEV1, if this is greater than 80%, they have stage 1, 50 to 79% stage 2, 30 to 49% stage 3, and less than 30% they have gold stage 4 COPD. Next, after assignment of airflow limitation, is to assess the patient's risk of exacerbations to guide the treatment. Remember, this is only a guideline and is not mandatory, but it is used to determine the risk of exacerbations. So you can see here from A and B, these are classified together and equal 0 to 1 exacerbations not leading to hospital admission, whereas C to D is greater than 2 exacerbations with greater than 1 leading to hospitalization. So for group A, it's recommended to add bronchodilators like albuterol. Group B, it's recommended to add a long-acting bronchodilator to the bronchodilator before. And then group C, this is where you add a long-acting muscarinic antagonist. And then group D, you add that or a LAMA plus LABA or inhaled corticosteroid. So it basically helps you guide the treatment based on their risk of exacerbations. So you can see from the previous slide that it's typically a stepwise fashion in treatment. You first start out with a short-acting beta agonist or a short-acting muscarinic antagonist, and then you add them together, and then you add a LABA or a LAMA, then you add both of those together, and then you consider adding an inhaled corticosteroid to the previous treatment. Now for the next few slides, I'm going to run through some of the common drugs that you'll see on rotation, but I would keep these in your peripheral brain. I don't expect you to memorize these for any of your tests. Common LABAs used are salmeterol, arformoterol, and formoterol, whereas common long-acting muscarinic antagonists include tiotropium, aclidinium, ameclidinium, and glycopyrrolate. Other drug combinations you may see on rotation include a LABA-LAMA combination such as a Noro or Stiolto, And then you may also see inhaled corticosteroid LABA combinations such as Symbicort, Advair, and Breo. Remember, combo drugs are very good to reduce exacerbations, however they can be quite expensive. Also remember that inhaled corticosteroids increase the risk of pneumonia, so you have to account for this when determining whether to start these drugs. Other treatments you may see on rotation include the newer drug that's a combination LABA, LAMA, and inhaled corticosteroid. Its name is Trelegy, and it's 1 puff per day. And information out there is showing that it may reduce exacerbations. Another drug commonly used is phosphodiesterase 4 inhibitors, or PDE4 inhibitors. This includes Dalaresp. It's the first actual oral medication approved for COPD. It's contraindicated if the patient has liver disease. It's very expensive, about $360 per month. However, there has really been no studies evaluated on its use for acute exacerbation of COPD. So it's primarily a chronic drug. Other treatments you may see on your clinicals include mucolytics, such as Mucomyst, which is N-acetylcysteine. Remember, this is also used for Tylenol overdose. There's also guaifenesin or Mucinex, and this can help thin the mucus so they can actually cough it up. Another drug is the methylxanthine theophylline, which is used as a last resort in severe COPD, mainly due to its narrow therapeutic window. This is typically not indicated in exacerbation as it can increase nausea, vomiting, which is the last thing you want in someone who's short of breath. Next is cardioselective beta blockers. So these actually used to be avoided in COPD. However, newer studies have proven that cardioselective beta blockers such as atenolol, bisoprolol, and metoprolol are safe and can actually decrease mortality in COPD. So this slide reflects other treatment considerations in COPD, but not necessarily treatment of exacerbations. People who get frequent exacerbations may require antibiotics, as they have been shown to reduce mortality and failure rate leading to hospitalizations. So when you're treating COPD on the outpatient basis, common antibiotics used include azithromycin, moxifloxacin, and doxycycline. The most common bacterial etiologies are H. influenza, Pseudomonas, and Strep pneumoniae. Remember, azithromycin and moxifloxacin cause QT prolongation, whereas doxycycline does not. Usually the treatment duration is 5 to 7 days. Vaccinations, including pneumococcal and yearly influenza vaccine, should be given to all patients with a history of COPD. Oxygen therapy, which is used when the ABG reveals a PaO2 less than 55% or oxygen sat is less than 88%, or slightly higher levels when a patient has hypoxia plus cor pulmonale. Now let's talk about COPD exacerbations, which you will be seeing on the inpatient setting. There are a lot of different guidelines out there regarding acute exacerbation of COPD. However, you always need to remember that these are only guidelines and used only to help guide care. These are not the end-all. One of the more common guidelines used was made by the American College of Physicians. It divides COPD exacerbations into mild, moderate, and severe based on major and minor criteria. So you can read through the criteria to determine the level of COPD exacerbation. However, clinically, you need to determine based on your assessment whether a patient is sick or not sick and let this guide your treatment. When treating COPD exacerbations, you should always start the patient on a short-acting beta agonist, such as albuterol. Now, studies don't support the use of NEBs over metered-dose inhalers. However, they are often used because you give the patient more breaths to get the medication into their lungs, rather than just 1 to 2 puffs through an inhaler. Also, you could also add an anticholinergic to this if needed. However, studies have been inconclusive whether this is more effective or not. This is what duo NEBs are, basically a combination of albuterol and ipratropium, which is a short-acting anticholinergic, whereas Spiriva is its long-acting cousin, tiotropium. One thing to remember though, don't ever use a SAMA with a LAMA together in BPH unless you want the patient to develop severe urinary retention. The next treatment is steroids, which I will address later, but I just want to say that there has been no proven benefit of using inhaled steroids such as budesonide on top of systemic steroids. However, clinically, we still do this all the time. Antibiotics. These should be used if all three cardinal symptoms are present. Those include dyspnea, cough, and sputum, or if only two of the three are present, but one includes increased sputum purulence, or if the patient is requiring mechanical ventilation. The three antibiotics used include azithromycin, moxifloxacin, and doxycycline. Remember, azithromycin and moxifloxacin cause QT prolongation, so these are contraindicated if the QTc is greater than 470. In this case, you should use doxycycline, which does not prolong the QTc. Then there's oxygen treatment. About every patient admitted for COPD exacerbation is going to be more hypoxic than normal, so you should place them on just enough oxygen to keep their SATs between 88 and 92% in order to prevent decreased respiratory drive. Now, it's important to understand that there is no discharge criteria that's actually set up for COPD exacerbation. However, the Global Initiative for COPD, or GOLD criteria, has suggested these discharge criteria. You can kind of read through these, but really the most important one is the very bottom one. Patient, family, and provider believe the patient can manage successfully at home. If the patient doesn't feel like they're ready to go home, it's better to just keep them in the hospital and keep treating them, as their chance of success is going to be so much lower if you send them home before they're ready. So here are just a couple pearls for COPD exacerbations. First, never use anti-leukotriene antagonists in COPD unless you have a strong component of asthma. Remember, these drugs, such as Singulair, are used for asthma, not for COPD. And then I wanted to take some time just to talk about steroids. So there are no set guidelines, but GOLD guidelines advise using the equivalent of prednisone 40 milligrams QD for most exacerbations. Although trials have not shown effectiveness over IV or oral glucocorticoids, they are generally used on admission, then de-escalated based on clinical improvement. Frequently used regimens include prednisone 30 to 60 milligrams daily to Solumedrol IV 60 milligrams to 125 milligrams BID to QID, depending on the severity. High dose versus low dose. There's really no literature showing high-dose steroids are any more effective than low-dose steroids. However, you will often see high-dose used initially in the hospital. These can easily be rapidly tapered down once the patient improves. Short course versus long course. Studies show similar risk of treatment failure and exacerbation between 5-day course and a 14-day course. However, a lot of times you will see a tapering dose used over a steroid burst. And then inhaled versus systemic. So studies have been inconclusive on whether inhaled steroids are safe to substitute for systemic steroids. So these are typically not substituted for them. In fact, most of the time I see physicians and pulmonologists actually add both systemic and inhaled steroids in the same patient at the same time. So if you have any questions or concerns regarding this lecture, please post them on the Google document, and here are my sources for this lecture. Thank you.